All right, cool. We'll start. So the goals is we're going to talk about BMI in bones and sugar in bones. The things I wanted to introduce to y'all was this website called Sci-Hub. I'm not sure how many of y'all are familiar with this, but when you're trying to look at a research article to answer a specific question, it's often frustrating to be roadblocked by, are you a subscriber to this journal? Here, buy now. And that series of clicks. This is kind of like the LimeWire or uTorrent for all research articles. And so you can copy and paste a title, a PMID, or a DOI on this, and over 90% of the time, you'll have a downloadable and printable or savable PDF. And so a really great resource moving forward. I talk about a lot of different articles in this presentation, and at the bottom, I try to have a link. A lot of the times it's a link to this Sci-Hub. It looks a little interesting, and some of the text can sometimes be like Russian, and so it can be a little spooky, but it's not. So we're going to talk some about obesity. So obesity is based on BMI. Greater than 30 is obese. Mine's 28. Mike Tyson, when he was at fighting weight, was 31, which shows that there is some kind of flexibility in that number, is how accurate it is. It is increasing and increasing, and between the 1980s and 2008, it's doubled. It's most common in Black and Hispanic women. It costs more to our nation. It's about 6% of our national expense in 2009, they estimate, or about $147 billion. And because we continue to have a more costly healthcare system and we continue to have more obese people, it's projected to cost about $490 billion in 2030. Here's a map of the U.S. It looks like Colorado is the only state that's doing pretty well, and I don't know how that's changed since munchies have become a thing. So in orthopedics, the obese population has a higher rate of meniscal tears, rotator cuff pathology, comminuted fractures, low energy knee dislocations, and Morel-Lavallée lesions. That shear force between all that extra redundant soft tissue can shear the vessels and cause these internal and degloving injuries. They also have a higher incidence of femoral neck fractures with ipsilateral femoral shaft fractures. So that's worth taking a little closer look at that CT scan that general surgery is getting. And they have a higher incidence of pelvic ring injuries. They have a decreased rate of type 3 open fractures, which makes sense because it's a long way to travel. And they have a decreased incidence of abdominal and intrapelvic injuries. It's also really hard to utilize a cast to help treat this population, both on the difficulty of keeping a cast on something that's cone-shaped and also challenges with putting a mold with all that soft tissue in between you and it. I would like it if Gotham would talk a little bit about these two slides or two pictures.
What about these two pictures?
I mean, yeah, what do you see that's applicable to you when you're helping take care of a patient?
What do I see that's...
I'll help you. So on the image to the right, we see how we have to position that pannus to be able to get a good start point for a femur flexion. Sure. We also see that when you're putting in a traction pin, your traction pin may struggle to be long enough to get through the obese population, and you may have to hover the stymie pin over the leg to see if it'll fit, or you may have to find a longer pin or find another means of traction. In addition, when positioning these patients, there may be more difficulty with padding extra tissue. For example, that pannus is putting itself on metal and needs more padding. And then the image on the right, when we're using our standard implants, we may struggle with the instrumentation. That's trying to put a femoral nail in, and that the guide isn't clearing the patient. So they had to do a subcutaneous tunnel to percutaneously put in the neck and head screws. So when operating on the obese, there are some extra challenges, such as positioning challenges. They have an increased risk of dyspnea when you put them in a Trendelenburg position. They take more time to operate on because their bony landmarks are more difficult to palpate. You often have to use a larger incision, and it's a more tissue to dissect down through. It's one of the soft indications for considering retrograde nailing. And if you're integrate nailing, you want to consider putting them in a lateral position. And if not lateral, you can put the perineal post kind of wedged in the contralateral size. You can adduct the leg a little more. You also have a more difficult time when you're placing your arthroplastic implants. You may need to do an intramedullary tibial tray or take more time in your surgery doing an intraoperative film. Additionally, an increased BMI increases your risk of infection, and most of the literature I found on that was in the context of acetabular fractures. There are also equipment limitations. CT scanners have a weight limit. X-rays have limited futility. I think we've all seen a hip fracture that had a big pannus hanging over it. Very seldomly does the X-ray tech pull it out of the way for the shot. Even our OR tables have weight limits. And then when we say, put skeletal traction on that patient, not only do we need to keep in mind that some pins won't span some thighs, but that putting 20 pounds on someone who weighs 400 pounds isn't going to really pull traction on their leg. Just the friction alone, their leg's not going to be pulled out. So for all people, you can do traction pin based on about 15% of their body weight. So they're going to need more weight. And then we talked about how with total knees, you might want to consider an intramedullary guide. Another thing, basic science about the obese population is they live at a low level, chronically inflamed state all day, every day. And what that does is it decreases their bone density and healing potential. There's some research that goes back and forth on whether they have more dense bone because of stress or if they have less dense bone because of inflammation. But all research agrees that they have a higher rate of arthritis, not just based on wear and tear, but this inflammation, as they'll have more arthritis in their hands too, and most significantly for us, in their knees. And so a patient with a BMI greater than 40 is 33 times more likely to request and have arthritis that's indicative of a total knee arthroplasty, which is challenging. So let's see. Ulmer, you've been to the VA and you've had a little exposure to some joints. What's kind of the teaching you were given on obesity and arthroplasty?
So the teaching over there, the protocol is that BMIs over 35 are prohibited for joints unless there's certain indications, and over 40 for sure is a no-go for most of those folks, particularly knees and hips. For shoulders, same. I know depending on the staff, there's some leniency there, but some of the joint staff over there have just hard cut off, and they won't even think about it.
Yeah, that's what I've been taught too. And so when we have kind of hard stops and dogmas, and I think those are kind of fun to explore a little more. So that's what we're going to do. So here's a paper. We got 9,700 total knees, population that's 48% overweight, 31% obese, and 2% morbidly obese. They have an average follow-up of 3 years with a range of 1.5 to 6 years. And they have their failures based on these populations all are about 2%. They find no significant difference up to 5 years. With a 2% morbidly obese population, that's about 200 patients that were doing well. Here's another patient, Piper. It's got 15,000 patients. Have an infection rate of an odds ratio of about 1.9 or vision rate of about 1.3 in the obese population. No difference in pulmonary embolism. And they find that there's about a 3-point difference in knee society score. And if you look into that a little more, that's like 3 out of 100 points. So I'd say not clinically significant. And then while we talk about how this population has a 1.9 times risk of infection, I think it's important to keep in mind that that is 1.9 times about 0.5% or 1%, so not huge. And then these papers don't control for other comorbidities or implant positioning. So they conclude that we believe obese patients should be informed of the above mentioned risks and should be advised to lose weight. Rare disagreement still. Several papers will say they have the same or similar outcomes in infection. Some will disagree. Some will say they have the same survivorship and satisfaction. There'll be some kind of confusing numbers sometimes in papers where they'll just use the odds ratios and not talk about percentages. And so they can say like 6.7 times higher and then say it's 1.1 or 0.3%. And they'll say about 11% less survivorship of implant or satisfaction, but you're not sure if that delta is the 11% or total percent. So when keeping this in mind, that the BMI of 35 of a rule doesn't have a really great foundation and has some significant limitations. We're not, one, doing a whole lot of surgery on these people, and so we're not generating a paper that can have a ton of power. We're not, when we do get a huge study with 10,000 patients or more, no one's looking through all the x-rays and making sure that all the tibial trays aren't in varus or valgus, which we talked about is harder to do in a big leg. we're not really stratifying for all the comorbidities that may be associated with obesity. And BMI itself has pretty limited accuracy when we're just putting height over weight. There's a little research in the hip arthroplasty too. They don't have a difference in aseptic loosening, but they do have a 3 times higher risk of infection. Again, 1 to 3% significant. They do have a higher risk of dislocation too, which is interesting, 4 versus 1.2%, even when a paper did account for appropriate acetabular cup placement. And what they hypothesize is that the redundant soft tissue medially is acting as a fulcrum and causing the hip to lever out some. And so when putting a total hip on a thick thigh, you may want to consider using a high offset stem. One of the, at the VA, I've had a couple patients kind of cry on me when you say we can't do your total knee because your BMI is too high, and they cite that they can't lose weight because their knee pain keeps them from exercising. There are a few papers that look at this. They are not of great quality, but there's not a paper that shows significant weight loss after a total knee arthroplasty when weight loss that is significant is defined as greater than 5%. And there's even one paper that shows that patients gained weight after total hip arthroplasty. Another interesting detail is that only about 15% of patients who are obese actually consider themselves obese. Another thing I think that is important to keep in mind when dealing with this population is that there's both a nurture and a nature component. These are all just syndromes associated with obesity, and some of these are ones that we learn about, like Prader-Willi, and others are ones that we will never learn about. Similarly, here's a list of all the genes associated with with weight gain or obesity. Another dimension to help you kind of look at obesity and orthopedics is that while obesity in this graph to the right has trended up and up and up, our reimbursement for many of our procedures, such as total knee and total hip arthroplasty, has gone down and down and down. And so you can argue that these procedures take more time. You could say that they have less reported satisfaction if you're saying 3 out of 100. I think it's a weak argument. And you can say they have a little higher risk, all while you're getting paid less. We've talked some about modifier 22 being something you can add on for this population. And it's nice that that allows you to bill for 20% more, but that only pays out about 1.6% of the times. And when you're trying to do that, you need to make sure that you're documenting the unusual circumstances. So a patient BMI was 38. We had to take more time with our dissection and palpating our bony landmarks, use a larger incision. We had to use an intramedullary and extramedullary guide. We had to use intraoperative x-rays, and this added additional 40 minutes to our procedure time. And then we're talking about maybe an increased risk of revision or failure. You can kind of keep in mind that that isn't something that really pays for itself. So to summarize some obesity in orthopedics, it's increasing in numbers in our population. There's both a nature component and a nurture component that I think we should be sensitive to. They present new challenges. They have an increased risk of complications. They're more likely to need a total knee, while at the same time we're less likely to give them one based on some kind of not super well-founded research we have that doesn't account for implant placement or comorbidities that can be confounding variables. There's not much research that's done on absolute weight for an implant, looking at local soft tissue like leg circumference or sub-Q fat or percent body fat, or like can you find the patella? And then our reimbursement is decreasing while this population that's at risk, that's going to cost more, is increasing. So I have here a question that I kind of like someone to talk through. Let's see. David Heath on joints. You have a 62-year-old male with a past medical history of hypertension and obesity. His BMI is 39. He works at the Red McCombs dealer. He was a nose guard at the local college. So he's a broad-shouldered man. He doesn't smoke. He fishes. He takes care of his grandkids for fun. He's done a leave. He's had a steroid injection that gave him a month and a half of relief. And you told him that low impact exercise and strengthening his quads can help. So he's been riding his bicycle 3 to 5 times a week. He's got severe tricompartmental knee arthritis. What are your thoughts on how to help this patient?
Well, my first thought was, I think we did a BMI like 60 knee last week. So, but yeah, when I talk to these people, I think it's important to tell them, hey, you fall into a patient demographic that puts you at higher risk of postoperative complications, especially wound breakdown. And there are things you can do to mitigate this before surgery. And then I kind of have a discussion with them. And it's kind of an awkward discussion about diet and exercise and stuff. And if it sounds like they've already made strides, then I think it's reasonable to say, hey, BMI 39, you're in a lot of pain. I think we can help you out. You're not a smoker. It doesn't look like he's diabetic. I think that's reasonable. If you,
Yeah.
yeah, if it was higher, then I might say, hey, let's have you lose 20 pounds. You do your part, then we'll do our part. I've heard Buttockwoley use that term before, and I like that too because I think that's a good predictor that post-operatively they're going to do what they need to do to get better.
Yeah, and some buy-in isn't a bad deal. And so the science is kind of hard to lean on with this based on what we've already talked about. Some people could be fueled by a bottom line. And we talked about how these surgeries take more time and do have higher risks. Some people will do kind of this carrot sticking where it's like, well, if you just lose a little more weight, we'll give you a total knee. Others will have a kind of a more paternalistic approach and say that you really can't consent a person about their risk for an infection because they really have no idea how bad it is being non-weight bearing for 6 weeks on IV antibiotics and then getting a knee that will never be as good after that and possibly having a risk of a above knee amputation. And so they'll just make the decision for the patient, say you aren't going to get it. But I agree with you, Dr. Heath. I really think that the shared decision-making model of trying to have a conversation where they're making an educated choice and knowing the risk and knowing, like you said, that they've tried to lose some weight and done what they can. The patient without these other comorbidities such as this isn't at an exorbitant risk of infection, and this is someone that I think you can really help. And I think that contrasts to like a 60-year-old female with chronic kidney disease, AFib, who's disabled with depression, anxiety, and back pain, who says her knee keeps her from doing anything fun. This is a patient that I think might benefit from continuing to try and lose weight before her surgery. So before we change gears a little bit, does anyone want to contribute or ask any questions about that?
Hey, Dietrich.
Yeah.
This is Trev. I was just going to comment. One of the few things I heard that Marky say that I thought was actually really beneficial, but he would phrase it from the standpoint that the patients needed to make sure they owned their disease or they owned their obesity. I guess they kind of took ownership that, this was something they could do something about. And it was a good predictor that they would own their post-operative regimen and they would essentially kind of be motivated to progress. And it was a good indicator that, people were going to do well with a total knee. And so I always thought that was a very interesting way to phrase it. And that was the way he would phrase it to people at the VA. He would say, you've got to own this. You've got to own, like, if their BMI of 40 or 44, he'd be like, you need to lose a certain number of pounds and you need to own this. Like, this is something that, you can do something about. And so I always thought that was a very interesting way to do it. I think it makes a lot of sense to me. But
yeah, and I think that if he does that and still has a hard line at 35, that's what I'm trying to kind of steer a little away from. I would say that this patient is owning it by trying to ride his bicycle, or like Heath said, maybe he's already tried and lost some weight. And that to me is someone kind of buying into the system and making an effort versus, I don't do anything fun. I'm limited by everything and I'm at higher risk. That would be someone that I would want to kind of buy some more time with. That's what I'm trying to highlight. And then a little transition here. Here's a little Halloween themed slide. And then I got another little brain rest. All right, so who likes being in the washout room, their surgery being undone or needing to be redone, potentially neglecting or harming their patients, longer inpatient admissions, or managing vent troughs and waiting for culture results? So let's talk about the sugar. So in a perverse way, this is somewhat pleasing, this graph, where we see that we as America are not the absolute worst nation by a huge degree. We have some other countries that are also struggling with this diabetic epidemic, and as expected, Europe is beating us though. Similar to obesity, diabetes continues to increase and increase. And in the U.S., we can again see how Colorado and this area is about the only safe zone. $327 billion a year predicted.
Minnesota was included in that.
Yes, right. The Midwest is doing best. And then more locally here in Texas, we got about 14% of our population. More locally in Bexar County, it's about we have about 1,000 amputations a year. We're cutting off about 1,000 appendages in our county for diabetes. It does have a little higher incidence in lower socioeconomic classes, with about 24% of people that only have some high school or are making lower income having diabetes. It's not just a problem for family medicine and our inpatient medicine teams. This population does have an increased risk of fracture, most notably in the vertebra, ankle, and hip. For some reason, they have a lower incidence of fracture in forearms and proximal humeruses. There's a thought that maybe so there's some protective obesity, maybe increasing bone density in type 2. That's a little controversial. But overall, they have an increased risk of limb fractures, about 20% increase. When they have these fractures, they don't do as well. And so they have a higher rate of malunion, about 6 times, a higher rate of infection, about 3 times, and a higher rate of reoperation, about 5 times. The healing time for their fractures is about 1.6 times. And of all the orthopedic infections in the Geneva hospital, 24% of the patients had diabetes. We knew that. And then we talked a little bit, then they have a higher rate of infection with knee arthroplasty too. So similarly to Omer's review of BMI, I'd like Dr. Lundquist to tell me what she kind of knows about A1C.
Like specifically related to orthopedics?
Yeah, you can add some more on. Just go for it.
Like in general, your A1C is a measure of your blood glucose over the past 3 months. So obviously, we would want people with more controlled sugars being below like an A1C below like 7, I think.
Yeah, below 7 is stellar. I think a lot of people will use a cutoff of about 7.5, or some people are generous and go up to 8 for elective procedures. And like you said, it's average or so, or thought to be of over the past 3 months for blood sugars in good control. So nice. Let's talk about that some more. So diabetes and total knee arthroplasty. Systemic review, 14 studies. Diabetics have an increased risk of deep infection. We knew that. Odds ratio 1.6. Increased risk of periprosthetic fractures. Odds ratio 1.9. More aseptic loosening, about 9 times. And have a lower knee function score, about 6 points out of 100. If you search A1C in arthroplasty, you find this paper cited 190 times, 4,200 joints. They look at infection in diabetic versus non-diabetic, and you see that the diabetics have about 3% infection rate versus about 1. They have about 5 times the deep infection rate, or about a 4 times risk of infection overall. And then if we look at total hip and total knee, we again see a difference between those two populations. And then we see that in those two populations, if we're doing a revision surgery, like a 13 times odd ratio and about a 4 times odd ratio. What they cite in this paper is that insulin versus non-insulin dependent patients was a big difference at about 8 times the risk of infection, and that there was no statistical significance of A1C. Found this interesting. So in the non-infected group, they had A1Cs up to 15 and as low as 4 with an average of 7. And in the infected group, they had A1Cs from 5 to 12 with an average of 7. Here's a retrospective cohort, 30,000 joints, and they do control for some other variables. And so we have in that first column, diabetes and hyperglycemia, and we're looking at pulling out different variables like age and gender. And when we pull out the most variables, we see in the right column that diabetes has a 1.23 times more risk of infection, and hyperglycemia, or a blood sugar greater than 180, has about a 1.5 times risk of infection. We see at the bottom that A1C greater than 7 is almost like protective in this population when we account for these other variables. They conclude that diabetes and hyperglycemia play a role that is largely mediated by other risk factors, including obesity, time, or ASA scores, and that A1C has limited value. Another paper still, 7.5 as a standalone has poor sensitivity and specificity. There is nothing special about it. Another paper still, looking at 17,000 total knees and an A1C 3 months before or after. They found that an A1C greater than 8 predicts infection slightly better than chance and should not serve as an independent or discriminator for infection risk. And the ADA says that they do not provide a recommendation for optimal A1C, but generally recommends it less than 7. So to review, diabetes has an increased risk of fracture, increased risk of malunion, increased risk of infection, and arthroplasty, they have an increased risk of fracture, infection, and loosening. They have a high risk, even higher risk of infection with revision surgery, and A1C is not helping us tease out what people in this population are doing well and what aren't. When we have a joint infection, that costs our system about $50,000 to $350,000. So this is a slide I took from one of DeHart's lectures. Then it's talking about ways you can optimize your patient for a surgery. And so getting their BMI down, getting put smoke in, getting their nutrition right, helping their kidneys, taking care of their vasculature, and that you keep optimizing and optimizing this patient until they're ready for surgery. And they just keep sending them these extra clinics until they're ready. So let's talk a little bit about hyperglycemia. So here's a meta-analysis of 32,000 procedures, not limited to orthopedics, looking at surgical site infection. They have an infection rate with diabetes about 1.5 times. They have an infection rate about 1.9 times with intraoperative or preoperative hyperglycemia, and then patients who have postoperative hyperglycemia about 1.4 times. These different papers will cite hyperglycemia ranging from 125 greater than 180 or greater than 200, so a little mixed. We have another paper that's looking at perioperative blood sugar in the morning, and it sees if it's above greater than 200 before their surgery, the risk of infection is twice that, is double. Or if they're fasting, if they don't have diabetes and they're fasting and their blood sugar is greater than 140, they have a 3 times risk of infection. I think that's worth pausing and looking at again. And so with diabetes, high blood sugar than 200 the morning before surgery, twice the risk of infection. Patient without diabetes, blood glucose higher than 140, 3 times risk of infection.
Dietrich, I want to just highlight something even more.
Yeah.
You already are, but going back to, you don't got to go back, but that your slide that showed the A1C correlation, a lot of people use, sorry, you don't have to go all the way back, but that correlation of A1C of 8 is an average glucose of 180. And then you fast forward to that slide there, pre-op glucose at 200, so just 20 above that average, and you've got now a 2 times risk. And then next morning fasting 3 times risk. You know, that to me is kind of alarming. You know how one, that A1C is kind of vague, and then 2, kind of what you're already obviously highlighting is that perioperative glucose control might be way more important than just like these generalized studies that say diabetes equals 1.5 increased risk or whatever, you know?
Yeah, exactly. Thank you. And so here's the relationship of hyperglycemia and surgical site infection and orthopedic surgery. They had about 1,900 patients that were not diabetic, so you and I. They had surgical site infections you're keeping track of, and if they had more than 2 blood sugars greater than 200, they had an odds ratio of infection about 3 times. If they had a average blood sugar of 140 during their stay, they had an odds ratio of infection of about 5 times. In this population, they identified that males greater than 51 were most likely to be hyperglycemic. And I'll kind of pause here too and highlight, I kind of became interested in looking at this because I remember being on trauma intern and admitting patients and seeing, you know, I just talked to the guy, he didn't have diabetes, but why is his blood sugar like 140, 150? And that's because this stress-induced hyperglycemia can happen from either trauma or from surgery when we have these hormones floating around. They increase our insulin resistance, trying to make fuel available to our bodies so that we can heal or move or run. But it also can really increase our risk of infection. Interestingly enough, hyperglycemia is also a risk factor for pulmonary embolism. With having a blood sugar greater than 200, you have about 3 times the risk of having a PE, which is higher than just having diabetes. It's also increased if you're old or if you're fat. And so when we revisit this optimization, I think it's important to kind of ask ourselves, what role do we play in this? And the argument I'm trying to present to y'all is that we play a very significant role in optimizing these patients during their stay with us in the hospital for their elective procedure. So modifiable by who? That's us. So what other intern do we have on here? Nat, will you talk to me about how, when you're admitting someone for trauma, how you manage their hyperglycemia?
So when you're admitting someone for trauma, you're going to take their blood glucose levels, of course, on top of their other labs preoperatively. And then depending on, what that level is, going to manage it by certain medications. I'm not too sure what the protocol is on trauma, but I mean, at least postoperatively, have them on a sliding scale. That's about all I know.
Yeah, I think that's about right. So let's talk about that some more. So sliding scale, I think, is kind of the gold standard for orthopedic department on how to manage blood glucose, and so we're going to explore that a little more. So here's a meta-analysis looking at sliding scale for blood glucose control. So they're comparing patients just getting a sliding scale to getting a more comprehensive regimen that would include a basal dose. And they found a mean glucose level of about 27 points. And so 27 doesn't sound big, but that's what it would take someone like you or I, who high for us is 120, into that greater than 140 range, which would triple our risk for infection. 27 also is what would take, like, sugars are a little high, in the 150 range to putting them in that greater than 180 range, putting them at risk for infection. They found that in those that were getting the sliding scale group, that they had higher incidence of hypoglycemia, and there was no higher incidence of hyperglycemia, right? We knew that. And then they have there's no difference in severe hypoglycemia between the two groups for length of hospitalization. Okay, so sliding scale lost. Here's a paper specifically written for us and this topic. It's looking at orthopedic residents and surgeons. They had a ward of orthopedists doing their best, doing the daily, doing the sliding scale, and they had a ward of orthopedists who were given 2 40-minute lectures and a weekly 10-minute chat over coffee about how to manage blood sugar, and then compared how the two populations do. In the sliding scale only about half the diabetic patients could keep their blood sugar below 180, and then the long-acting population, about 3/4 could keep it below 180, so 20% difference, significant. And then just to kind of review some more med school information, the reason this is important is when we're given that sliding scale, we're playing whack-a-mole, but we're closing our eyes for 4 hours in between strokes, and so what happens here we have no control over, versus when we give a basal dose, we're just cropping the top of everything. And so what was going to be 180 peaks all day is now 160 or 140. That's why that's better. Another interesting component to trying to keep these patients from being hyperglycemic and at a higher risk for infection is how we manage their NPO. So the university diet of having a patient that has an infection and not wanting to put him in a room because it'll delay turnover, getting paged at 10 and at 3 asking if and when they're going to go to the OR by the nurse, but prioritizing our important cases and then kind of forgetting about them. And then after shift change, getting a page at 10 p.m. and asking if that patient can eat, and then deciding if you want to do a washout at 10 o'clock at night or push it to tomorrow. That will cause insulin resistance, and they'll be hypoglycemic for part of the day, and they'll have very rebound hyperglycemic that you'll be chasing the whole next day. What we want to do is try and limit the periods of fasting for these patients. If we can, we want to schedule them earlier in the day. We won't always be in the system. We'll have some more control when we're practicing on our own or in a different system, and so we might have some more control over both scheduling of our cases, and then also being able to put someone on a clear liquid diet until 2 hours before our procedure. It's a little tough here with different anesthesiologists doing different things. Some hospitals, though, will even give a pre-surgical carbohydrate drink to diabetic patients and or give intraoperative feeding because it will keep their blood sugar at a more treatable level. I also think it's important when you're going to have someone in PO, whether it's until 10 p.m. or not, to go ahead and put them on an IV fluid or to give them a clear liquid diet if that can work. Because these patients do have decreased kidney function. You know, polyuria is one of their symptoms of diabetes, and they don't control their electrolytes as well. So what do we do with this information? What I'm really trying to highlight is that we have these modifiable risk factors that we're holding our patients accountable to that aren't super hard lines when we look at obesity or when we look at A1C, but we have a pretty hard line here with hyperglycemia, I feel, that is modifiable, but it's modifiable by us. And so we can help prevent infections in both the diabetic population and the stress-induced hyperglycemic population. And in order to do that, we need to first identify that problem and then gain some comfort in either managing their blood sugars ourselves or engaging medicine. When a non-diabetic patient has a blood sugar greater than 140 on average, or when a diabetic patient is hitting 180 consistently. So don't be overwhelmed. Here's some quick review on how to just be a little more comfortable with insulin treatment. And this isn't just so you become a medicine doctor, which is our greatest fear in our managing this, but also just so that you feel more comfortable continuing a patient's home medicine. You know, I myself have been guilty, and I've seen other residents guilty of admitting a patient who at home is getting 30 or 40 units of insulin, but not really feeling comfortable starting that and just putting them on the sliding scale. And what I'm telling you factually is that we're hurting the patients by doing that. So we'll use me for an example to talk about what an insulin schedule can look like. I weigh 100 kilograms, which is convenient. And so when you're supplementing someone's insulin, you're giving about 40% of their body weight. So for me, that'd be 40 units. And that 40 units is divided between what you're given for a basal dose and what you're giving before meals. And so I'm getting 20 units as a basal dose, and 20 divided by 3 is 6 units with meals. When it comes to basal doses, you can either give MPH, which is that same dose twice a day, or glargine, that dose once a day. And the sliding scale is just like the icing on the cake. It's bonus. This is really where the magic's happening. So in treating diabetes, you want to give a basal. So instead of saying 40 divided by 2, right, you could say 20, right? So the basal dose is 0.2 units per kilogram. So for a 100 kilogram person, 20 units of glargine at night or MPH twice a day. And that's just half of their insulin needs. So that's not scary. I called the endocrinology team and talked to them a little bit about this too. And I asked, you know, we're talking about this hyperglycemic population that has a blood sugar greater than 140, but isn't a diabetic. I'm a little nervous about this. What do you think? And they said, well, one, it's good to get an A1C regardless, just to see if they're diabetic and they don't know it. And then two, they said that even myself as a healthy young male, if I took 20 units a day, if I'm eating a diet, I will not become hypoglycemic on this. But that if I was still scared, I could cut it in half to 0.1. Another kind of barrier to care for us on this is what do we do when they're in PO? So if you're given the night before, if you're given MPH, you give them the regular MPH dose, so nothing to do. If you're giving them glargine, which you're given at night, you cut it by 25%, which would be the same thing as taking their dose times 0.75. Also not super complicated. The morning of MPH, you give a half dose, and they would get no AM glargine. Another thing I think that would be beneficial for us to do is intraoperatively to also keep this in mind. I think we can be more specific than just asking anesthesia, how's he doing? You know, we can ask, you know, what are the pressures? You know, how's he statin? And then if it's a case longer than 2 hours, I think it'd be nice if we're also making sure that anesthesia is keeping in mind to treat their hyperglycemia too. And then postoperatively, we want to get these people up and eating, restarting their insulin. We want to get them home, and we want to get them following up with their PCP as soon as possible to keep their sugars tuned. I think another kind of barrier for us to feel comfortable with this is the concern of hypoglycemia and the concern of hurting someone. And I think that every good medicine knows that they learn in medical school that tight control of blood sugar is more harmful than lax control of blood sugar. And so I wanted to kind of talk about that paper too. So that paper is looking at intensive control of blood sugar between 81 to 108, which is very different from less than 140 or less than 180. That paper is also in the population of ICU patients, which we are not managing except for when we are interns and someone else is helping us. And the mortality rate in that ICU population difference was only about 3%. But if we're still nervous and we still want to be smart about hypoglycemia, it's good to know how to treat it. And so it's a blood sugar less than 70. And if someone's awake, you can treat it by 15 grams of carbs, which is half of one of those 8-ounce Cokes on the floor. Pretty simple. Or if they're unconscious, you can say 1 bag of sugar, or which is going to be 50 milliliters of dextrose, or you can give 1 milligram of glucagon IV or intramuscular. I think also well within our cerebral capacity. We can do it. So the goal here is to recognize a problem and do something. Sliding scale is not enough. We want to give a basal dose, and if we're too scared of giving that 20%, we can give at least that 10%. So I sent out an email asking about questions people had about basic science. My next lecture is going to cover more of those, but I'm working one of those questions into this lecture, and so someone wanted to talk about fructosamine. And so we've already cited how A1C is not an accurate predictor of complications. We also say that A1C cannot be accurate, period. In the African American population, it's not as accurate. In elderly, it's not as accurate. If you have anemia, malnutrition, or high blood cell turnover, it's not accurate. And fructosamine is a newer kid on the block that instead of measuring glucose attached to hemoglobin, as Lundquist pointed out, is looking at glucose attaching to albumin. Albumin has a life cycle of 3 weeks versus 120 days of a red blood cell. So the number for fructosamine is over 292 is bad. And so here's a paper about 800 joints, 10-month follow-up, looking at A1C versus fructosamine. They found that a high fructosamine had a 6 times risk of infection and a 3 times rehospitalization rate. 40% of those that had a high fructosamine had a normal A1C, and then A1C had no correlation to bad outcomes. Another study with 1,100 total needs, 12-week follow-up, had an 11 times increase of adverse events in patients with a high fructosamine, and A1C again showed to correlate. So fructosamine is a more accurate predictor of adverse outcomes. A 3-week picture allows you to more quickly see if you're treating their diabetes better, but also may allow you to have them come back and schedule surgery a little sooner because you can see if they're getting better and if they're the right window. The test costs $20. The number needed to treat is about 280 patients, which is $55K, which is significantly less than what it costs to wash out and treat an infected knee. Of note, though, we talked about some shortcomings with A1C in patients with red blood cell issues. This fructosamine cannot be as accurate in patients with protein issues such as cirrhosis or nephrotic syndrome. A little bonus fun fact is that the Maillard reaction, that's what gives bacon its sweet flavor, or Heath was just talking about the char bark on barbecue. It's what gives roasted coffee its sweet flavor. Is this like glycosylation of proteins when you cook it? And that's what this fructosamine is, which is kind of cool. And then another fun fact is when you're doing steroid injections in diabetics, you will impact their home glucose for 3 to 5 days, which is not much. And there's at least one paper showing you won't impact their blood sugar at all. And so I don't think you have to limit a person just to one glucose injection a day. Sorry, one steroid injection a day in clinic. So we're going to kind of, and in military lectures, they tell you what they're going to tell you. They tell you, and they tell you what they told you. So we're going to go through, I'm going to tell you what I told you again, part of the lecture. So big bone review. Obesity is increasing in numbers. There's a nature nurture component. Population presents new challenge with planning and instrumentation. They have a higher risk of complications, about 2 to 3 times in infection and dislocations. They're more likely to need total knees. And while we have a pretty strong doctrine against doing total knees in our bigger patients, the literature is not a a solid foundation for that when it doesn't account for implant placement or stratify for other comorbidities. There's not much research on absolute weight, leg circumference, or sub-Q fat at the surgical site. And then this is a population that continues to increase and will continue to want total knee arthroplasties with higher risk while reimbursement is decreasing for them. For some sugar review, diabetes has a higher risk of fracture with malunion infection, and arthroplasties, the diabetics have a higher risk of periprosthetic fracture, loosening infection. But when stratifying these patients, A1C is not helpful to figure out which diabetics are going to have a bad time and which are going to have a good time. More importantly, we can look at a tighter perioperative window, whether they're intraoperative and admission blood sugars, or looking at a narrow window of fructosamine, that 3-week window. We can do better as orthopedists to take care of our patients' blood sugars in both the diabetic and the normal hyperglycemic patient. It's a modifiable risk factor that I feel we have a duty to pay attention to. What questions or concerns do you have about that?
Diedrich, this is Andy again. If I could just tag along with that. Thanks again for, I think that was awesome. You put a ton of work into that, highlighting something that we all find boring, but really need to maybe do a better job of engaging in. And one, especially the perioperative blood glucose, I think you highlighted too, sometimes we have people who aren't actually diagnosed as diabetics. And I think the reality is, as we experience here, it'd be nice, we're orthopedists and you talk to us about bones and we're stoked. But you talk to medicine about medical problems and they're typically just like trying to run as fast as they can to like their next, afternoon rounds or something, and really don't want to help us out. And they really don't have much skin in the game for our perioperative period. And so as nice as it would be to have a hospitalist who is stoked about keeping glucose at the right level, I worry that I'm going to go out and practice and I'm not going to have that support, and I need to be somewhat smarter about it. And then the fructosamine is something that I had asked Diedrich, because I was completely unaware of that until I was listening to this webinar, and all of a sudden these arthroplasty guys were talking about how they had completely abandoned using A1C and all their decision making was based on fructosamine. I was like, holy crap, I don't even know what that is. All that to say, I don't think we've seen that used too much here, but that isn't like this experimental thing out there, but it is something that's really gained some traction in the arthroplasty world as being used as a marker. And so far, the evidence seems to suggest that it's a bit more accurate in at least in regards to predicting things. And then the last thing I wanted to bring up, and I know this wasn't the point of your talk, but that one study you mentioned about diabetes affecting things, and you mentioned a 9 times increased rate of aseptic loosening. And if you look at more recent studies, just talking about why are arthroplasties failing today, they like to highlight, hey, our polyethylene is so much better, and we're not having to do revisions for polyethylene wear. And currently, the most recent study that looks at this, they're like these, reviews of 20,000 plus arthroplasties done at these huge centers. The most common reason for late revision is aseptic loosening. And so that to me is also a pretty freaky thought of just looking at that factor. And we really don't talk about that much. Where anytime we're talking about diabetes, we're always talking about infection. But that's something too that was, something that I haven't thought of that much, but definitely more worrisome. And we don't really have a great answer for that. Like, how do you prevent?
That's a big number, 9. And it'd be nice if there's a paper that stratified the diabetic population to neuropathy and not, and if that played a role,
Yeah.
But to your first comment about a medicine buy-in, for sure, and I think if we can put ourselves in a medicine resident shoe, and we're getting paged by an ortho resident for someone's blood sugar being 147, it would be hard to be excited about that.
Right.
And so I think my goal was to try and make it attainable to where we could do like the first phase of doing that 10 or 20% basal dose to get a head start and keep track of it and care. And then I think to help our conversation with medicine, if the patient's on a carb-controlled diet, has a basal dope, and we've ordered an A1C and their blood sugars are still high, I would think they'd be more receptive to that conversation than just kind of that quick pass of, hey, this guy's blood sugar is 145.
Yeah.
Yeah, I just recently, I just went through a lot of this last week, and I ended up calling medicine. And it's funny because I got put on speaker and I was talking to the attending. It was great. And I was just like this dumb ortho guy that can't manage glucose. But I was like, hey guys, so I haven't done this in a couple years, and I know they need to be on some kind of long-acting glucose. Can you just help me figure out what the regimen should be? Like, it doesn't have to be like this big thing. And they were super receptive too.
Awesome.
So, yeah, I think it's how you frame it, more than just calling and being like, you guys need to manage this. I don't do it, blah, 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 and being an asshole, or just coming down to their level and being like, hey, I realize this is dumb to call you about it, but, this is not what I know. And actually, in that patient, we ended up getting a fructosamine. He ended up being kind of complicated, so I was glad I called. But
Nice.
yeah.
And one thing I do feel like is important to add too, just to reiterate to any juniors who are more frequently in the process of admitting someone and it's chaotic. I've seen and I have done, I will admit, look and see that they've got like this complex insulin regimen, and I'm like, man, like I'm busy, I'm flying, I'm just going to put them on an insulin sliding scale, and we're not going to even worry about this. We're orthopedists, which is, as you showed, Dietrich, a very, very wrong thing to do.
Yeah, we were in House and I were talking about this and joking. We were joking how, but we were good residents, and so we didn't just do the sliding scale. We put them on the big sliding scale, because we knew the answer. And so again, hindsight, very foolish, and we can do a lot better. All right, well, thank you all for your time. Let's get to work.